Since morning we are talking about a lot of things, and the first and most important thing why we are here is to understand what is the goal of total knee replacement. We are hearing it since morning multiple times that the goal is to relieve pain, is to improve function, and to increase the longevity of implant. Now, this longevity of implant is the most important part, and as we know the anatomy, that there are two axes, mechanical axis and anatomical axis. The mechanical axis of lower limb is like from the center of hip to the center of ankle, going through the center of the knee joint. And the anatomical axis, as the name says, it is anatomical to the shaft of both long bones. And there is a joint line oblique joint line, which is JLO. It is 2 to 3 degrees in varus in a normal situation or a normal patient. And with this information, Dr. John M. Insall has proposed us the mechanical alignment, which we saw early in the morning with Dr. Sunny Google showing excellent performance of mechanically aligned TKR. So in mechanical aligned TKR, we cut 90 degrees to mechanical axis of femur. We take proximal tibial cut perpendicular to the mechanical axis of tibia, and similarly to make the rectangular gap in a flexion, we cut parallel to the transverse transepicondylar axis to achieve a rectangular flexion gap and rectangular extension gap. So by and large, our HKA is 180 degrees in a mechanically aligned TKR. And Dr. Sunny showed beautifully that it is highly reproducible technique. The advantage of this technique is that it is there since last 40 to 45 years, and it has a proven track record. As we heard that there are still 80 to 85% of orthoplasty surgeons are doing mechanically aligned TKR. But what is the disadvantage? It is a fit to all technique. Each of us are going to have the same type of mechanically alignment if we go for TKR. That is, there are still 20% of patients who are dissatisfied, and there are few patients who says that their knee doesn't feel natural. So to have more anatomical thing, Dr. Hungerford and Krakow proposed the anatomical alignment TKR, where they gave importance to the oblique joint line. So we cut femur in more valgus, and we cut proximal tibia in more varus, like 2 to 3 degrees of varus, to bring our joint obliquity or oblique joint line to 2 to 3 degrees of varus. But it is not supported by literature a lot. And just adding one small thing, because it is a hybrid technique called as adjusted mechanical alignment. It is neither mechanical, it is neither kinematic, but where we take a perpendicular cut of proximal tibia and we adjust our femur according to the joint laxity patterns. For this type of alignment philosophy has been applied for severe deformities where the joint line obliquity is maintained. It is a hybrid type of alignment. I will talk to this again when we go to the kinematic alignment. So we are all are not same, and the same has been explained by many authors like Belaman Magdesi group and the Hirschman and Moser group, where they say that there are multiple phenotypes of our knee joint. So we can have a 180 degrees of HK, but still our femur might be in varus or tibia might be in valgus. We might have a varus, but our femur and tibia might be in 90 degrees. So these phenotypes are also been explained by a CPAC classification by Belaman and Magdesi, that there are 9 type of phenotypes of a normal knee. So are we going to impart all this type of knee with a mechanically aligned alignment? So now the targets of doing TKR are shifting from not restoring the HKA to 180 degrees, but restoring it to the pre-arthritic alignment by doing minimal soft tissue release and maintaining the joint line obliquity to the pre-arthritic position. Similar thing has been explained by Stephen Howells in 2013 by a kinematic alignment knee. So he explained that there are three axes, two horizontal axes traversing through the lower end of femur, over which the tibia moves in flexion and extension, one transverse axis over which the patella moves in flexion and extension, and a vertical axis in which the tibia moves in internal rotation and external rotation over a femur. And these two axes are usually either parallel to the transverse, the posterior condylar axis, or perpendicular to the posterior condylar axis. And reproducing these will actually will actually lead us to the kinematic alignment. So what are the principles of kinematic, or which is called as unrestrained or unrestricted kinematic alignment, where we do not bother to change the pre-arthritic alignment. We just replace the surfaces and we remove the exact amount of bone thickness which will match to the implant. So we just remove distal femur and posterior femoral cuts which will match to the exact size of femoral implant, and similar for tibia. So in a workflow of a kinematic aligned TKR, we take distal femoral cut first and second cut as a posterior femoral cut which will match the implant, and then we take a 3° or equal amount of bone from the tibia which will match the tibial implant, and whatever residual laxity is available or which is remaining will be adjusted by further taking tibial cut. We do not cut any soft tissue release, or we do not release any soft tissue in purely kinematic aligned TKR. So the disadvantage in extreme situations, there might be a varus failure of tibia, and more varus may loosen the MCL, and if you take more varus in tibia, your flexion gap might be affected. So to negate this problem, there are two alignment philosophies were put forth, like inverse kinematic alignment, where you take a tibial cut proper as a first tibial cut and then match your femoral cuts to the to make it parallel. Again, if required, you can do a minimal soft tissue release. And in a restricted kinematic alignment, where you take first cut as a femoral cut, then you match it to the tibial cut, you can, but the boundaries are set where you cannot unrestrictedly cut tibia in varus, but the boundaries are 5 degrees on either side, and more preference will be given to the tibial side changes. And now we are in a functional alignment era, where with the advent of robo, we can actually change the position of tibial implant, we can actually change the position of femoral implant, we can change into the we can have a control over axial position of the implant, and a graphical representation of the gap balancing. So there are those people who are using robo will understand this workflow, whether after obtaining our gaps, whether we should move femur or whether we should move tibia, depending on which type of alignment philosophy we want to go along. But there are some boundaries where the HK axis or the terminal HK axis should be around 6 degrees of valgus to 6 degrees of varus to 3 degrees of valgus, and similar boundaries are set in for tibial and femoral component. So in summary, on extremes we have a constitutional alignment, where we want to put every patient into a mechanical alignment, 90-degree femur, 90-degree tibia. In anatomical alignment, we want oblique joint line with valgus femur and varus tibia. In a unrestrained kinematic alignment, we do not want to we do not want to do any soft tissue release, but surface match the femur and tibia. But in a hybrid way, where the reverse kinematic alignment or adjusted kinematic alignment, where we can actually change tibia or femur or both in a functional alignment. So to take home message that the post-operative alignment is reason for and a solution to the post-operative dissatisfaction. Respecting soft tissue envelope is utmost necessary, and the functional alignment philosophy recently which has been put forth, which will achieve the alignment targets. Thank you.